Hello and welcome to today's webinar, Demonstrating Value, Measuring the Value and Impact of the Healthcare for the Homeless Grantees. I'm Brett Poe, and I will be the moderator for the webinar presented by the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. We'd also love to get input and feedback as you listen to the presentation about how you demonstrate your value at your own site or how the HCH provider community has been of value to you. A select number of questions will be answered at the end of the presentation during the Q&A session. Remaining questions will be logged and provided to the presenter for written responses after the webinar. If you are having technical issues, you may also call the Council's office at 615-226-2292 for assistance. The PowerPoint presentation and the recording of this webinar will be posted on our website, www.nhchc.org, within 3 business days. Our speakers today are Dr. Elena Boyer. She provides oversight and guidance for the research activities of the National Healthcare for the Homeless Council, which includes quality improvement projects and providing educational resources for healthcare clinics that serve individuals experiencing homelessness. Dr. Barbara DePietro directs the policy and advocacy activities for the Council. This includes conducting policy analysis, providing educational materials and presentations to policymakers and other stakeholders, coordinating policy priorities with national partners, and organizing staff assistance to the Policy Committee and the National Consumer Advisory Board. Rick Brown is the Communications Manager at the Council. He's responsible for developing and coordinating the Council's ongoing communications strategy and digital storytelling initiatives. And Heidi Nelson is CEO of Duffy Health Center, providing HCH services on Cape Cod, Massachusetts, where over 3,000 patients are served annually. Heidi previously served as Executive Director of Heartland Health Outreach, the ACH program in Chicago. She has a master's degree in health administration from the University of Michigan School of Public Health. Heidi has been the chair of the Administrators Committee of the Council for 3 years and has served as board chair and planning chair for the Council in the past. So we'll go ahead and get started with Elena.
Hi, and welcome, everybody. Thank you for being here today. I'm just going to give a quick overview of our agenda. I will briefly do some framing around the deliverable that we produced regarding value and the HCH grantees. So I'll do a brief background, and then we'll hand it off to the next speaker to talk about value analysis in the absence of HCH. And we'll also have Rick Brown talk about his HCH stories from the community, and then we'll also have our guest speaker, Heidi, talk about value from the lens of a health center CEO. And then, as Brett Poe said, we will be having a Q&A session at the end. So there is a disclaimer at the end. This is a HRSA-supported product, and so just so that we are aware of where the support for that was coming from. So just to give you a little background about the deliverable that we will be making available in mid-August. It has not been released yet, but I just want to give some highlights from that, that product. And so we started when we were thinking about how do we frame a value statement. We were asked from some of the members from the National Healthcare for the Homeless Council in our community to say, hey, we're looking for a deliverable that we can use when we're sitting at the table with decision makers, and how do we show our value in a quick way? How can we have a reference material to show who we represent and the work that we do and make that distinct and special from other community health centers? So it's a bit of a daunting task, but one way that we started, especially being a national lens, given that every healthcare for the homeless health center is unique and distinct, we looked at, well, what is our value statement since we're a real reflection of our health centers? And so one of the things we feel that we add value to at the Council is really strengthening clinicians and programs that serve people experiencing homelessness and really provide some best practices, lived experiences, and research and policy around some of those issues. And of course, we also provide training and technical assistance to help support those efforts. So kind of looking through that lens, we decided to say, okay, well, what is the purpose of the HCH grantee? What do they deliver? They deliver care to underserved populations, and specifically individuals experiencing homelessness. We also touch on areas of what do we define as value, which there are multiple frameworks that have been published, which also made it very difficult to kind of hone in on which ones to focus on for our community. But we did touch on cost effectiveness. There's also areas of performance measures that can be used to define value, access to care, quality, and equitable care, all of which can be represented by our health centers. So in this white paper deliverable that we will have available in mid-August, we do start by saying, well, who do we serve? What is the population that we tend to deliver care to? We already know that our population experiences increased mortality, increased comorbidity, and chronic conditions. Their conditions are often more complex and is also intertwined with behavioral issues. They experience trauma, either from past experiences or on a daily basis, and continuing trauma. And how does that play a role in decision-making for their health? We know that a lot of health conditions among our populations can be exacerbated from their environmental day-to-day activities, as well as other trauma-related problems. And there's also a difficulty with linking individuals experiencing homelessness to some health conditions and outcomes because there's a lack of linking using the ICD-10 Z codes for social determinants of health. If we link to have a better linkage there, we'll be able to track and define our population a little bit easier. In the most recent UDS deliverable that came from HRSA, there were 1.2 million individuals experiencing homelessness served across all federally qualified health centers. 94% of those were served by Healthcare for the Homeless grantees. And you can see here in the figure a few of the statistics that we point out that make our population unique. So also in this white paper, we talk about, well, what are our providers do that provide value, and why are we distinct from the larger national healthcare providers? And so there's a lot of training that goes in. There's a lot of being trauma-informed. There's a lot of key elements to the integrated care that needs to be present at our health centers. And so our providers and nurses and any staff that really provides that delivery of care really represent a lot of these core competencies, and that's something that we're very proud of, and there's value in that, and how the patient is treated and experienced on when they walk through the doors of our clinic. We also looked at how do we measure value. So we started looking at our funding announcement that we received from HRSA. To exist as a national cooperative agreement, we do have to respond to some funding announcements. And so looking at the criteria that they use to say what makes the National Council valuable for funding, we started there, and the three items that pop up is access to care, quality improvement strategies, and health equity across our population. And so we stayed with those core domains throughout the rest of the deliverable. And so we defined those differently. So access, we looked at what are the availability of resources, what does connection of services and linkage to care look like among our health centers, and what is the responsiveness of our health centers to the learning health system. Looking at quality, we wondered, well, we know that we deliver meaningful and deliberate care. We offer state-of-the-art comprehensive care as well as preventive care. And then in the last domain, we looked at equity. We tend to believe that we put community-first care. We deliver fair and tailored care, and that care is delivered in a respectful and a trauma-informed manner, which, again, I think has us distinct from the larger community health center. Over the past 5 years, the grantees for Healthcare for the Homeless have increased over time. A few other items that we have in this deliverable as well. We talk about what are the types of services that our Healthcare for the Homeless centers provide, and more than 90% are providing care and case management, followed by HIV screening and education, as well as substance abuse services. When looking at quality of care, this is using UDS data from 2015, you can see that one of the measures or metrics that HRSA uses to measure quality improvement is linkage to care. And among our health centers that receive health care for the homeless funding, we do a significant job at that. So we do more than 75% are linked to tobacco screening and cessation. Also, more than 70% receive asthma management, and so on and so on. So lastly, and I think what's most important, is how are our services tailored to our population. So there's a lot of times where some of the work that we do at our healthcare centers cannot be captured accurately in a data set. So what does that look like? And so we were able to analyze some qualitative data and some write-in responses to the UDS deliverable reporting structure from our grantees that they felt were services that they provide but were not necessarily captured in the larger UDS Uniform Data System data set. And so some of those under professional services include dietitian and nutritionists, occupational therapists, and physical therapists. Secondly, in enabling services, a lot of our clinics might offer art studio types of services, as well as housing specialists and lodging and shelter help. And related services, also related to medical respite and other HUD assistance or needs in that area. And so the size of the font is reflective of how many times a health center said that that was a service that they provided. In a recent study that was published in an academic journal, it did show that individuals that went to tailored non-veteran, non-VA services had better experiences when treated by those health centers versus health centers that aren't tailored to the health care for the homeless community, as well as other mainstream VA hospitals. And so this is a study done by Stefan Cortez. And so across all domains, relationship cooperation, access coordination, and homeless-specific needs, individuals had better experiences, again, among health centers that were tailored specifically for their population. And so on that note, I am going to hand it off to Barbara, our Senior Director of Policy. Barbara?
Thanks, Elena. Appreciate it. Really excited to talk about value today because I think that value is the framework that so many of our systems at our local and state levels have been using as we've approached our healthcare system delivery reforms, sometimes payment changes, and alternative ways of approaching how providers are paid and looking at outcomes, and value is typically the phrasing that is used. And a lot of times we think about, what is value? And the framework that Elena just pointed out is a lot of that nationally, but so much of this comes down to what are we demonstrating at the state and local level. And so sometimes I think maybe it's easier to think about value in terms of the inverse, if we were not here as HCH grantees or as homeless healthcare providers, what would the environment around us look like in the absence of our services? And then we can start filling in what that added value is that we bring. And so from a community impact, I was just thinking about framing this in terms of how would other providers in our community be able to serve the patients that we serve? Or would they be able to serve them? And we know that the model of care that we use, that Elena just went through in detail, is a model that is very unique to what we do. We think it's an evidence-based practice. We think this is a model of care that works well. But we know that many other providers may be missing some of those pieces. And that's what makes the work that we do very unique. So maybe thinking about it in terms of how would or whether other providers would be able to pick up the patient population we're serving. So then when we think about this from a broad community basis, we know that there's larger public health goals and initiatives that many states have set targeted goals. So how are we bending the curve on diabetes or obesity, cardiovascular disease, some of those chronic conditions, or some of our behavioral health? We know there's a lot of attention in a needed way around the opioid addiction, around mental health. So how is it that our community would look different if you didn't have the targeted services and approach that the HCH model brings? Violence and injury are increasingly a public health goal. When we look typically at emergency departments and crowding, sometimes these public health goals, when we look at diversion in emergency rooms, because all the beds are filled. Well, if we had a more efficient system in our community because of the HCH provider, which is often able to divert some of that patient population out of the emergency room, maybe you wouldn't have the degree of diversion. The impact on hospitals, again, from a community impact piece, might be a framing that you can use to demonstrate your value. Police and first responders, again, all of these are stakeholders that we engage in our work. How would their jobs be harder if they didn't have us as a partner? And then just thinking about the fact that we think that there would be more people experiencing homelessness, and we would have a greater visible impact of homelessness on our streets. So when we think about demonstrating this, some of these things that we might think about are, what are the data that we can use to demonstrate those connections to care, illustrating disparities and how we're able to lower those. What are the lower risk behaviors at a macro level? That's some of the data that you might think about in terms of a community impact. When we think about this, though, in terms of value, and what value do we bring to individual patients, again, I'm thinking about lowering risk factors. How is it that there would be greater levels of homelessness at the individual level? Our patients would struggle more. They would have a harder time getting out of homelessness. We would see more people coming into homelessness because of the work that we're doing really to keep fragile people in housing and to get people off the streets and out of shelters and into housing. And so absent that work, what would that look like? We know that there would be higher morbidity and mortality. It would be more difficult for people to engage in care, particularly in fragmented systems, which a lot of our communities still have. It's very hard to navigate programs and access services without some of the case management or outreach or some of that warm handoff that we're able to do. And when we think about this again, about patient impact, we think about this from a very human impact perspective. We obviously are using a human rights framework in that we believe that healthcare and housing are human rights. So this is often really the interventions that we are doing are the right things to do. And they bring value because they meet the moral code that a decent community has. And so thinking about how is it that we're connecting people to employment, we're reconnecting them to their family, we're getting people into housing, and we're able to document those kinds of numbers, I think really demonstrates our value at the individual level. Greater screenings like colorectal screenings and SBIRT, intimate partner violence, BMI and PAP, all of those kinds of screenings that we know are part of a good standard of care is the kind of work that we're doing every day with a patient population. Absent us, they may never get those screenings. And so thinking about what's the local data that we can put to that at an individual level. And then finally, cost. And I purposely put cost last because I think value too often gets defined solely in terms of cost. And so I really do think that it's important for us to think about this more broadly in terms of community and communities and people. But we need to be realistic too. And we are talking often about how do we leverage the kind of attention that we need is often through demonstrating return on investment and cost savings. And so thinking about this about, as an FQHC, why is it that payers should pay us more for the model of care that we bring? And so how do we demonstrate this in terms of reduced emergency room visits or hospital inpatient admissions? What are those lengths of stay? Can we attribute any changes in our community to the work that we're doing with our patients? And this might be frequent user initiatives or high-cost user initiatives, some of those things that really target specific patient populations. This can be really hard to demonstrate, but at the same time, really looking through your data to figure out how you might be able to work with that and demonstrate that as a partnership is really helpful. And so, again, I've just given some possibilities that you might look to demonstrate through your own data, but I think in terms of value, what would our communities look like absent our model of care? And then that can be your answer, and so that might be a framework. That's just some things to think about. Again, all communities will be different. And so with that, I will pass it on to Rick, but really welcome a discussion at the end about how you might apply some of this to your own work. So at that point, Rick, take it away.
Thank you, Barbara. One useful tool for demonstrating the value of a unique approach in populations served by healthcare for the homeless is storytelling. By telling simple stories about our consumers, whether through text, photos, or videos, we can highlight services as well as health and housing outcomes in a way that illustrates their value while putting a face to our consumers. While these stories cannot take the place of data in illustrating value, stories can help make real and personalize the impact of our work, particularly to a broader public, in a way that data sometimes cannot. For example, a story of a consumer who received care at an HCH organization that they otherwise would not have been able to reach can highlight value it provided in terms of access. A tale of culturally sensitive interactions between consumers and providers can illustrate value in terms of equity, and so forth. These stories can be useful not only for illustrating impact, but also for development purposes and advocacy. One example of an HCH storytelling initiative is the Council's HCH Stories project. HCH Stories is an online video series that seeks to highlight the experiences of providers, consumers, and administrators in healthcare for the homeless. To do this, we gathered video footage through one-on-one interviews at our 2016 National HCH Conference, later editing these interviews into short videos that explore what HCH means to individuals involved in the field. You can find some of the videos we've released so far at nhchc.org/HCH Stories. But to illustrate the series now, I'd like to show you a story of Calvin Alston, a consumer leader from New York. Calvin relates his story about his experience of homelessness and how he received care from Care for the Homeless.
My name is Calvin Alston, and I became involved with Care for the Homeless when I became homeless. It was my 25th birthday. I was having a party at my house and left my house to go get a haircut. Came back and see these fire trucks, and I'm like, what are fire trucks in front of the building? Come to find out, the iron was left on, and it became electrical wire in the wall, and it burned down the whole apartment. Not only did I have guests coming, but I had guests coming up with food, balloons, and I sat on the stoop while I watched them destroy my apartment. You know how the fire departments do, and they destroyed it, you know, and that was in 1989. From then, I was referred to the Red Cross, and Red Cross referred me to Care for the Homeless. I'm from New York. I live in Harlem. And Care for the Homeless in New York helped me get back on my feet. So my motivation was I wanted to help somebody like the people helped me. And I've been in my apartment 10 years and successfully have completed my certificates in advocation and peer education. I'm also on the ACT board at Care for the Homeless, and I'm presently now going to start a new term as chairman of the board when we get back to the city. I also am the supervisor for the outreach department, which is a motor home that we take out to the streets, and we find homeless people who don't have insurance, who haven't had an HIV test, who hasn't had a hepatitis C test. We motivate them to come in and get help, a primary doctor, and try to help them find some stable housing. I say homelessness is a very big part of my life now because I'm really trying to let people know that you can be homeless and pick yourself up and become a successful part of society again. It's going to take a little bit of time, but with the help of the work that I do and the work that everyone else that does here at this convention, we can stop homelessness. I thank everyone that does the work that they do, may it be here in New York, here in Portland, California, wherever you do your work at. It's important to that community to have somebody like that in that community because each one teach one. You will help your brother, help your sister out, God will give you blessings back.
Sorry for anyone who experienced a little bit of lag there. That being said, this is only one example of the possibilities for telling stories to illustrate value. Furthermore, The stories that your organization tells don't need to be as complex as an edited video to be impactful. The stories your organization can tell can be as basic as a photo. Something as simple as a before and after photo of a client who received care can tell an important visual story. So, too, can a simple quote from a consumer, particularly if it illustrates or supports a specific data point about your organization. Storytelling is something your organization can do with minimal resources. All you need to get started is a notebook, camera, release form, and a small investment of time. One of your greatest resources for these initiatives can be your consumer advisory board. Involving them in such a project can not only help illustrate the impact of your work, but also to help to highlight consumer voices and leadership. Once produced, these stories can be disseminated via your website, incorporated as sidebars and reports, or shared to your community via social media. In whatever form they may take, however, effective stories will help highlight the unique value of HCH at your organization and in general. And with that, I'd like to hand things off to Heidi Nelson, CEO of Duffy Health Center.
Thanks, Rick. I'm very pleased to be invited to speak to you all today. I started thinking about how we represent our value to the community when I attended the National Association of Community Health Centers Policy and Issues Conference in March, where we were challenged by NAC leadership to make the case for the value that health centers bring to the system. I went home to my office and created a slide deck that I titled Duffy Health Center, The Value Proposition. And over the past few months, I've been copying and pasting data and findings into my slide deck. I must have mentioned this to an HCH staffer, and that's how I ended up here today. Before we proceed, I think it's important to, Before we proceed, I think it's important to say that most of us went into this business because we believe that it is a human right that everyone should have health care. And this is the full intrinsic value of what we do. Although we're talking today about economic value and the value associated with quality health care, let's not forget that the work that we do promotes social justice. In general, value is described and defined in terms of economic efficiency. In healthcare, that efficiency needs to be balanced against the need to achieve the best outcome for the patient. I liked this slide because it talks about the movement in the healthcare system toward results, not input, not volume, but the value of the outcomes that we receive. So one more introductory comment and then we'll dive in. I want to be sure that you know that this talk is not about Duffy Health Center, but it's about how we can emphasize the value that healthcare for the homeless brings to the system. So I'll be talking about the value that Duffy Health Center brings to our community, but these are just examples for you to plug in your own data and your own information. So as you can see here, we'll start talking about the 5 types of data and findings that you should consider when making the value case. So first of all, we'll start with your own health center data. And the sources that most of you, hopefully all of you, are very familiar with, the Uniform Data System and how that comes back. The information comes back to you in summary fashion. There's also something called the Bureau of Primary Healthcare Profile and your own quality reporting. So let's look at some examples of those. So you all, I'm sure you can look at your own UDS data, but what happens at the Bureau of Primary Healthcare level is that they use that data to put together a Bureau of Primary Healthcare profile for each health center. So all you have to do is Google the name of your health center and then BPHC profile, and up on your Google search will come your profile, and you just click on it and take a look at it. It's derived from your UDS data, and it very nicely compares your data to your state's data and then also to national health center data. So you can use that, as you can see, this is what I did for Duffy Health Center, to pick your favorite scores to prove the point that you want to make. So for our data at Duffy, for example, you can see that we implemented PHQ-9 screening in 2014, 2015, and you can see the dramatic increase in depression screening. You can see that our scores are pretty good for an HCH program with having blood pressure under control for our patients, especially when you consider that comparing this number to national averages for all populations are around 50%. And you can also see that we've, in the third example, uncontrolled diabetes, you can see that we've made progress over that 3-year period in reducing uncontrolled diabetes. So all this information is available to you just by Googling your Bureau of Primary Healthcare profile. Next, we'll look at national association data. So earlier in the presentation, there was information from the NAC website and great statistics there that you can share in your communities that nationally we're a large movement. 1,300 health centers, 23 million patients served. About 8% of the American population receives their health care at community health centers. 9,000 sites, and 1 in 3 persons, so 33% of people who live in poverty are served by health centers. Those are pretty amazing statistics. But then they also start to talk about the studies that are out there that show our value. So NAC has the data to demonstrate that health centers save $24 billion for the health system annually, and that health centers are associated with lower cost of care for Medicare patients. You can see the numbers there. And for Medicaid patients, when they compare patients served in community health centers versus patients who are served in other settings. Then also on the NAC website, you can see linkages to many state research projects that have been done that show the effectiveness of health centers. So Medicaid costs lower rates of multi-day hospitalizations, less likely to use hospital-related services, less total costs, annual savings per patient. In Georgia, there was a study that showed that health centers have lower ED visits for uninsured patients, and in North Carolina, they had a study that showed that health centers have lower total health care spending. And of course, as Alana said earlier, another national association to turn to, of course, is the National Healthcare for the Homeless Council. So nationally, last year, 2 years ago, HCH programs served over almost 1.2 million patients. Vast majority of them very, very poor, under 100% FPL, high rates of uninsurance, lots of children, lots of people in the general public don't understand how many homeless children and youth there are, and then of course the fact that we have 5% of our patients are people 65 and over. So seniors and homelessness is a very compelling story to tell. Another source of data that you can look to is any data that you have available through your state primary care association or other state type of data. In Massachusetts, we are members of the Primary Care Association, which is called the Massachusetts League of Community Health Centers. And every few years, they do a report for each individual health center called the Economic Engine Report. And in this report, in Massachusetts, this report is produced as a joint effort between an organization called Capital Link, which provides services to community health centers, and the League. And they usually do this before the Policy and Issues Conference so we can take our information to Washington. So because I'm not a highly skilled in PowerPoint, I just want to show you the infographic. The actual data didn't come up when I shrunk the infographic, but you can see the different sections of what the Economic Engine Report includes, how many jobs we create, what our impact is on the economy, savings to the healthcare system, and the fact that we provide access to care for vulnerable populations, as Barbara very eloquently said. So the data that didn't fit in that slide, this is the Duffy Health Center data, shows that we provide 52 jobs. 21 of those jobs are skilled jobs, 11 are entry level. They have a calculator that takes our total budget, which is really around $6 million, and figures out what the total economic impact of that spending is by our employees, and how our health center spends money and then our employees spend money. So it's a total of $9.2 million in total economic impact. The generation of tax revenues, both state, federal, and local, And then the statistics again about reducing costs for Medicaid patients. And our state association actually was able to say that Duffy Health Center, so the $7 million saved annually, is specific to Duffy Health Center. I was able to use this data very recently. There was a very negative letter to the editor in our local newspaper about the burden in our little community of all of these social service agencies and how they attract people who are poor to come to our beautiful resort community. So I was able to effectively make the case and got a number of kudos about how we actually provide an economic benefit to our community. So another source of information related to value of HCH programs is to look at any special studies you've been involved in. Most of you may be familiar with the concept of social innovation financing. This is where private investors, foundations, and state governments can invest in models that work and then pay a return through the savings. And we've been doing this now in Massachusetts. We've been involved in this project for about 3 years. It's an initiative of the Commonwealth and the Massachusetts Housing and Shelter Alliance. Massachusetts, for those of you who've been around for a while, the MHSA, MHSA, is actually Philip Mangano's organization. He's retired now, and others have carried on the baton. But it builds on the success of two programs. One is called Home and Healthy for Good, which is a state-funded line item with flexible dollars to serve the chronically homeless. And then another program called CSPEC, which is actually a source of funds for us to bill the Medicaid program for housing support services. We're not supposed to say case management. We're supposed to say housing support services, but that's what it funds. So this is our data. We partner with our Low-Income Housing Development Corporation here locally, and we have done, the vulnerability index on 104 patients. We've housed 21 patients. The units that we have available, a number of units committed through this program is 30. You can see and we're supposed to have those units over a 5-year period. There's a research project that goes along with this to demonstrate the savings to the system. And so that was year one. Pay for Success is the name of the program, and the evaluation outcomes for year one are pretty dramatic. Reductions and this is, of course, not new information to all of you, but the infographics are pretty powerful. So nights in emergency shelter, major reductions there. Days of hospitalization, major reductions there. Same for days in detox units. Days in jail, incarceration. And then finally, housing stability is really what we're looking for with these kinds of programs. So 305 patients who are clients who've been involved in this program continue to be housed, which is an 87% retention rate. So these are pretty powerful, as you can imagine, pretty powerful statistics. Another source of information is grant or program outcomes, grants that you may have participated in. So I'll use 3 examples. One is the HRSA Quality Awards. The second is state data that you may have available related to addiction treatment. And then finally, special grants, and in our case, we were part of the Behavioral Health Integration Expansion grants. So you can just do the same thing that I said before about your BPHC profile. You can Google HRSA Quality Awards, and it'll pop up to give you a place to click on a link that takes you to the list of health centers and their quality awards. And I extracted some of the information related to Duffy Health Center. And as you can see, last year we received almost $50,000 in a quality award because we are using an EHR to report our data. Clinical quality improvers just means that we were able to improve in some of our scores over prior years. Access enhancers just means that we served more people in 2016 or 2015 than we did in 2014, and then there's a nice bonus in there for PCMH recognition. So what's nice about this data is that you can show it to your stakeholders, and clinical quality improvers and access enhancers are really nice data points that you can describe to your audience. But also the fact that you're reporting your data through an electronic health record is a way for you to explain that we use these sophisticated systems for providing healthcare services to our patients. Not everybody understands that, and certainly they aren't widespread in physician office practices out there. So I think for the general community to know our involvement in these sophisticated systems is important. And then, of course, PCMH recognition is a huge summit to climb, and so our constituents ought to know that we are involved in those kinds of projects. So program data, again, another example. Office, we call in Massachusetts MAT, medication-assisted treatment is called office-based opioid treatment is the name of the state-funded program. And I receive 3 or 4 times a year a report from the state that shows specific data points on our clients that are involved in MAT at enrollment, and then same data points at disenrollment. Now, it's really important when this is not an official university research study. This is just me, Heidi Nelson, sitting in my office looking at the information about our patients when they enrolled, about patients who enrolled in the program and patients who disenrolled in the program. This is not a longitudinal study. It's just looking at those data points for people when they enroll in the program and those same data points for people who have disenrolled in the program. But you can draw some pretty good conclusions. I always qualify that this is not official data, that this is just my review of our own program data, but you can see that we show when you compare people at enrollment to people at disenrollment that we have higher rates of employment, decreased homelessness, and decreased dependence on public assistance. Those are powerful data. Then through our HRSA Behavioral Health Integration Grant, and if you're coming to the conference, you can see our team was selected to do a presentation on the Bridge program. We have a team funded through the BHI that is a community health worker, a psychiatric nurse practitioner, and a therapist that goes as a team to visit our hospital, which is just a couple of blocks away, the inpatient psychiatric unit and the day program. They go twice a week to meet the patients that are identified by the staff at the hospital as people who might be eligible for Duffy services. So you can see through this program 203 patients had received these types of consults over the period that we have this data for. And of the remaining 172 individuals, you can see all the people who kept medical appointments, kept behavioral health appointments. Overall, 90% of the patients who received those consults engaged in at least one type of Duffy Health Center service, so we're pretty proud of that. So my parting advice to you is start your slide deck today. In fact, I went to a conference yesterday about another state grant-funded program that we're involved in, and the Harvard evaluation was presented at that program, and so now I have a few more slides to add to my slide deck. And with that, I will turn it back over to Alana.
Thank you, Heidi. That was great. Thank you for sharing all of that and what you do at your health center. And I just want to remind those that are listening to share with us your experiences and how you demonstrate value within your community at your health center as well. So, and that's, again, open just in the chat box. But as I had started out this webinar talking about this deliverable that we'll have available in August, in addition to the highlighted data that I shared, we also have some other suggestions that might help get you started on showing and demonstrating value at your health center. So some of the ideas, and this is not an exhaustive list by any means, is to collaboratively share metrics and data and trends with other local agencies that might be in the area and publish those findings. identify what benchmarks are most important to your health center. What are you mostly seeing in terms of conditions? What quality improvement metrics are you proud of that you would like to show in a dashboard or something of that nature? And then have somebody help maintain that dashboard and have it available on your website so that it can be showcased and visualized. And also, again, kind of keeping in mind linking health data to housing as well, kind of showing that value and linkage to not only health outcomes, but how are we improving the social determinants of health around that individual or patient or population. And one other thing to do to celebrate as well is Healthcare for the Homeless Day will be August 16th, which is in the middle of National Health Center Week, which is put on by NAC. And really kind of share your voice from your perspective and lens in that way. And you can celebrate in your own communities, too, to bring attention. And also on that day, and I do want to mention, is that we do have, the National Council has a storytelling guide that will be coming out that was put together by our consumer advocate, Catherine Kavanaugh. So that should be coming out soon. But what's unique and great about that is, along the same lines as Rick, is how do we tell a story to show value? And that value is not only embedded in data, but the human impact and the ability for humans to tell their story and the personal story within the context of a broader social issue. So thank you, Catherine Kavanaugh, for putting that together, and hopefully we'll get that out to everyone in the next couple of weeks. But it had been vetted and written through our National Community Advisory Board. So we're excited about that. And lastly, one thing that the National Council has put together is an infographic. And putting together infographics are a great way to show really quick facts and data in a short and compact way. So it can be front and back. And here's our example that you see on your screen now from the National Healthcare for the Homeless Center. And again, since we have the national lens, you'll want to tailor something like this to your local areas as well. But you can see we have outlined how we improved access to care, what kinds of quality and tailored services do we offer to patients, and then what is that benefit and that value to communities, like Barbara shared with us, in a great way to show value. That is also on the back side of our infographic, you can see specific conditions related to tobacco and asthma and heart disease and HIV, which again comes from our UDS system as well, like Heidi was showing. So this is a very important opportunity to show value, and before I conclude, I do want to show that on the back of this infographic, we do have a comparison of what it looks like for individuals who are experiencing homelessness to those individuals that do have homes, and kind of where they fall within each health condition as well. So it can be very impactful in short amount of space and time. So hopefully we've shown today that you can tell, or you can demonstrate value that's the best way that's fit for your community. Figure out what your framework is, since there are multiple frameworks out there. And think about the different lens or perspective are we sharing it from. Is it from data? Is it from the patient? Is it from the health center providers? What perspective are we talking from? Who is the audience? And so I guess I'll leave it there, and I just want to thank all of our speakers, and I think we're going to go to the Q&A now. So I see a question from Valerie Steinmetz. When is the storytelling toolkit coming out, and how do we make sure we receive the communication announcing its release? We will definitely have that in our National Healthcare for the Homeless Council News. I think that would be correct. Rick, if you're still on the line, you might want to have a better timeline or time frame for that. And I do see that it will be posted today, and it was just approved through HRSA. So that's the answer to that one.
Yes, thank you, Elena. And then another question that we got was that from JAMA on June 13th published value-based payment models for community health centers time to cautiously take the plunge. Is there a plan to change the volume to value in terms of HRSA metrics? There are still cost per visit and total costs of care per patient that may not be the best metric for team-based care. Barbara, I don't know if you might be the best person to respond to that one. Do you have any thoughts?
I'm looking at this now, and I'm trying to expand on the whole question. I'm sorry, I can't see the whole question, so can you repeat it, please?
It was that JAMA on June 13th published value-based payment models for community health centers, time to cautiously take the plunge. Is there a plan to change the volume to value in terms of official HRSA metrics? There are currently still cost per visit and total costs of care per patient that may not be the best metric for team-based care.
I completely agree. I can't say what HRSA's policy changes might be coming in this regard, but I can say that the volume versus value piece is a legitimate friction point, because national goals for the last several years have been about increasing the number of patients that health centers have been able to serve, and that's been related to the years of increased funding affiliated with the Affordable Care Act, just to be able to build out health centers. And so there's been this push to do more to demonstrate how those dollars are being used. But at the same time, we are also trying to shift to value. And I know there's also a natural friction point between doing patient-centered medical home and doing a deeper and more intensive care model for the people that we already serve, and at the same time trying to serve more. And so it is very hard to see more people, but then do more services per person. And I think that this is a very valid, almost dually, in some ways, opposing goals. And so, in fact, Heidi, I'm sure you probably have a perspective on this, given that you run a health center and are also trying to balance some of those kind of dueling perspectives there. So do you have a perspective on how that might change in the coming years for you?
We are embarking on accountable care organizations here in Massachusetts, and so the whole value equation has been kind of turned on its head, as everybody is moving in that direction. So at our health center, we're looking at our incentive program and how we adjust our incentive program. And we're really just kind of taking a wait-and-see approach. Like, we're all struggling with the fact that we still get paid based on volume still at this point. We don't get paid for quality yet, in some cases small amounts. So I think we're kind of in the same place that everybody is in. It's just an awkward time, and it's a case to be made for continuing health center funding, because we need that base support in order to keep everything going while we're transitioning.
Sorry, we just got a response from Catherine Kavanaugh, who released the storytelling guide. She let us know that that may not be released nationally until August 16th. But if anybody on the line is going to be attending the HCH Council's conference next week, I know that there will be some preview packets available there. And then before we go, unless anybody else has any other questions they'd like to type in, one question that I had during the presentation was, with all of the different ways of defining value and the different approaches to take with this, for all three of you really, is there any one of those areas that you think is the best or most attainable way to demonstrate your value, or what are maybe some of the biggest barriers that you have to answering that question?
Well, sure, I can start. This is Elena, and I think for me, I'm trying to put together the value white paper and putting together deliverables. Some of the challenges we had was really around data, if we wanted to use numbers to show value, and looking at some of the cost effectiveness and looking at readmission rates at hospitals. We don't really necessarily have access to the data, and it's been somewhat scattered, so that's kind of been a little difficult from that standpoint, because you have to piecemeal across different data sets to do that. But to me, I think one of the most valuable things is kind of the patient experience piece. And I think with the storytelling guide and kind of what is the impact that we have on the actual individual that we're treating, is probably, at least to me, maybe one of the most impactful pieces of value that I try to focus on. And one thing I do want to mention quickly is that we do have resources available that we've mentioned throughout the presentation at the bottom of the screen. So you should be able to click on some of those PDFs and get some of those deliverables as well. And along with the story guide, the value paper, when it is released, we do have active links within the white paper itself, where we have stories kind of going along with each of those sections that we mentioned earlier: quality, access, and equity. So that would be my response.
I would add, this is Heidi, I would add that I think one of the big challenges here is, and as you saw through my presentation, I was really trying to synthesize a lot of different inputs into making the value statement. And healthcare is very, very complex. And trying to explain this to stakeholders who are used to now listening to things in sound bites, and sometimes the second point I wanted to make is that for us, really making baby steps in the right direction can have a huge impact. And so something, when you're able to move the dial. I was at this, as I said earlier, I was at a presentation yesterday of a prevention and wellness trust program that we're a part of. And they talked about the impact of these community-based interventions that we're referring our patients to who have hypertension in particular. If you can move the average blood pressure measurement for somebody just a couple of ticks, it saves millions and millions of dollars. So it doesn't look very dramatic on paper, but the impact can be hugely dramatic. So I think those are some of the challenges in taking something that's extremely complicated and breaking it down for the average stakeholders, a business owner in your community who doesn't understand why there are people out on the street who have not chosen to be sober yet, and trying to explain that to somebody. And what you're doing and the impact of what you're doing on the overall system can be very challenging.
Great. Thank you, Heidi. So that will conclude our Q&A session. Thank you for joining the HCH Value webinar produced by the National Healthcare for the Homeless Council. This webinar will be archived on our website at www.nhchc.org within 3 business days. A link of the archived webinar will be available to registrants once it is posted to our website. Questions that presenters were unable to respond to will be addressed via email if possible. At the close of the webinar, an online survey to evaluate will automatically open in your web browser or will be sent to you. Please complete it so that we are able to improve your webinar experience. Please visit the NHCHC website for a listing of upcoming council webinars and other educational products. This meeting will now be closed.